presentation. As I already told you, we're going to go over the presentation that was given by my colleague as the refresher to all the clinical coordinators and health educators during the last regional meeting last August. So it was a really great, refresher, and I'm going to utilize the slide. So, thank you to Dr. Polikar. Let me show the first slide. I want to, why doesn't show the first slide? Hold on 1 second, please. Let me just do it manually, so I apologize for that. Um, I want to give a huge thank you to Dr. Polikar. He is Professor Emeritus of OBGYN at the San Francisco UC, University of California, San Francisco School of Medicine. And he's been our colleague for many, many years. He's also a medical consultant. He's not, with with the state. He was a contractor, but he was overseeing the activities of our sister program, Family Pact. And we've done a lot of, great project together because a lot of things that we do are kind of overlap. So today I'm going to present the development in cervical cancer screening, management, and prevention. We're going to talk a little bit about management of the abnormal, but not to the depths of that. So let's kind of start from the very beginning. So screening for the cancer in the United States, especially for the cervical cancer, was one of the most successful efforts. We were able to get 70% reduction in cervical cancer deaths in 80 years. This is really incredible, number. Um, so why we were so successful? First of all, it's the invention of liquid-based cytology. um, I don't know if some of you may remember that in the past, when we did the pop test, it was the slide, and we would just smear the cells, on a slide and put it under the microscope. But in the last more than 25 years, we started to use liquid-based cytology where we put the specimen into the special, preservation liquid, and that test is much more sensitive. Also, another, huge accomplishment, as I told you before, is the HPV testing itself. So we're not just looking how the cells have been changed, but we're also trying to identify whether or not the woman carries HPV. And depending, what kind of HPV, we can triage and co-test and decide what to do with that. And also, the way how we manage all the abnormals, whether it's HPV or abnormal PAP, uh, the guidelines has been changed tremendously, and we're going to talk about it a little bit later. But those guidelines have been consistently changing over the years. So every single time they're more and more tuned into more individual, assessment. And again, I'll show you, what do you need to, download. And I think we've talked about it already when I was, presenting you our overall EWC presentation, and I'm talking about ACCP, guidelines and the application that is available on any of the smart devices and also online. And of course, probably number one preventative measure right now is the HPV vaccination. And although we don't do the vaccination in our program, nevertheless, this is really the most, drastic measure to prevent, cervical cancer. And you absolutely have to understand what HPV infection include, and you have to be comfortable discussing it, with population and with the providers. So this chart shows how the incidence rate by race and ethnicity have decreased, in the last years. Of course, the data that you're looking at, it's almost 10 years old, but there's always a gap. That's why, before we will have, where we are, at this moment in time, a few years will lapse. But as you can see, uh, we have the decrease in all the in all the ethnic and race, background. So we were really able, to fight cervical cancer successfully. And, the most, advanced progress we were able to get with um, American Native and American Indians. So you can see that their numbers, have really dropped. But, all the other, race and ethnicity have been positively affected by the screening programs and also by the vaccination. So, of women diagnosed with the cervical cancer, 50% have never had cervical cancer cytology testing, and 10% have never been screened in 5 years. And that really speaks to why, we have this indicator. If you remember indicator number one, that we have to screen at least 35% of rarely and never screened women, because that's where we find most of the cancer. And that's been, challenging for EWC, because not a lot of women, have, zero testing in the past. Nevertheless, there's still women like that, and it is extremely important for our health educators to continue um, outreach and really try to get women who never been screened or rarely been screened, either under EWC coverage or any other coverage that they might be eligible for. So, what can we do? As I said, the outreach methods, it's also reminders for those who've been screened infrequently, due to the fact that the schedule is not really annual any longer, because in the past we used to screen women every year, now every 3 to 5 years. It is extremely important to make sure that women are being reminded where they are due for the next time of the screening. And especially, it's important to reach out to the immigrants, from the countries where screening is not a norm, and especially those who are high risk. And probably, the most of the advances that our program was able to reach is really with the immigrant community, especially with Hispanic women, due to the nature of our state. Okay, so this is the slide that I really want you to kind of, understand and memorize. So, human papilloma virus infects the normal cells, and we've talked about it a lot. And what it does, oh, sorry, and what it does, it persists, within the cervix. And when we look at the pap test, we oftentimes can say, yes, these are the cells that are affected, by the HPV. Those cells are harboring HPV. Nevertheless, those lesions is not necessarily a precancer per se. It just shows us that the virus, persists in those cells, and we call those lesion LCIL or CIN1. With time, though, if the virus continue to persist, it can go to precancerous lesion. And even then, when it's a precancerous lesion, it doesn't mean that it will ultimately, results in the cancer. Some of the women are able to clean, the infection and progression of the cancer, and we call it regression. Nevertheless, unfortunately, some of those cases will persist, precancerous lesion will persist, and it can go into the invasion and true cancer. And those lesions that we call precancer, in other words, is the high um, epithelial lesions, squamous epithelial lesions. That's why you see this abbreviation, high squamous intraepithelial lesion, or CIN2 and CIN3. So CIN2 and CIN3 we consider to be precancerous condition. Any questions here? And I just wanted to show you that, this is the picture of the cervix, and this is how precancerous lesions look like. You see the, abnormal vasculature, and you see also abnormal, whitening, of the surface of the cervix. So let me just show all the bullet points. So most of the HPV infection clear on its own, and that's important to remember. So having an HPV doesn't mean that, you're going to develop the cancer. Those that doesn't clear, we call it persistent infection. As I mentioned before, the incidence of the HPV infection tends to decrease with age. So it means that as women gets older, the less likely you will find HPV in her. Nevertheless, the risk of persistent infection, meaning that the virus is being harbored by the cells, increase with the age. And persistent infection with HPV can progress to cancer and precancer. Also, we will spend some time talking about a specific type of the HPV, 16 and 18. Those are the most dangerous high-risk HPV. First of all, they have higher tendency to persist, and they are identified in almost 70% of all the adenocarcinoma of the cervix. And those are the cancers that are included in all the available vaccines. So these tables show you the type of the HPV that most commonly you come across with the cervical cancer screening, and also when you do the vaccinations. So I don't know if you can see. Are you able to see the presentation? Little window. I'm trying to move it so it's not on your way. Um, so the HPV type 6 and 11 are benign HPV viruses. They're also the part of the uh, vaccinations that prevent against cervical cancer and papillomas, mucosal papillomas. But 6 and 11 never would cause any kind of cancer. Those are benign HPVs, but they do cause papillomas on the mucous surfaces. So I don't know if you ever seen any pictures, but those condylomas, look pretty nasty, and of course, uh, there is a lot of concern among people who have those lesions on their genitalia, but they can be on other mucous surfaces, and that's the reason why the vaccines also include those viruses so we can prevent development of condyloma. Their progression risk is none. They don't integrate into the nucleus of the cells, and all we find, on the lesion is condylomas and low cell lesions. They don't cause the precancer. Then we have quite a few viruses. You don't need to remember them, but these are the numbers for the high risk viruses, but their risk progression is intermediate, and they do integrate into the nucleus. They do cause the cancerous changes, and they cause the low-grade cell lesion and high cell-grade lesion and cancer. And they're approximately responsible for 33% of the cancers. And then, as I mentioned before, the HPV type 16 and 18, they are the truly high risk HPV types. And these are the types for which we are testing any HPV positive results. So once you have HPV positive results, we do genotyping. So we type for specific type of the HPV, and our management is different when we see type 16 and 18. And we're going to talk about it at the next slide. But they're responsible, as you can see, almost for 70% of the cancers. So the progression risk is super high. Nuclear integration does exist. And again, it can cause a low-grade lesion, high-grade lesion, and cancer. So this is a very nice chart that shows the progression of CIN by the type. So as you can see, type 16, is responsible for the majority of the cancers, and then goes type number 18, and then the group of the high risk cancers that are responsible for 30%, and then the green line indicates the low risk or benign HPV. And as you can see, these are the types that only, responsible for low grade lesion. Apology. um, Look at the X axis. So this is the number of the months that women have been followed. And usually, on average, we are saying that it approximately takes, around 10 years for those persistent infection to cause true cancers. It can be quicker. We see that, in some women who have been negative, we can see cancer even in a couple of years, but that's usually not the case. And that's why, we have this kind of a very prolonged period of time during which we test women. That's why we have, 5 years benchmark for the HPV testing and 3 years um for pap test. So it's at least 10 years of the progression. Any questions? So another important topic is that this cancer, those viruses can not only cause cervical cancer, but they can cause any other cancers that can arise from the mucosal epithelium. So first of all, we're talking about head and neck squamous cell carcinoma. And the organs that can be affected by those viruses that can cause the cancers: oropharynx, hypopharynx, sinonasal tract, and nasopharynx. So this is the sixth most common type of cancer in the world. What are the other additional risk factors to the head and neck cancer? Of course, it's the smoking, it's the alcohol consumption, and also battle chewing. Um, Most of the time, it's the HPV-16 that is the main risk factor for development of the oral squamous cell carcinoma. So let's talk about cervical cancer. So we've talked yesterday about cytology, so now you are comfortable with this term. Um, so primary HPV screening or HPV alone test for 14 high-risk strains of HPV, and we only have two FDA licensed tests. One is the Rosh-Cobas, or we call it Thin Prep or SurePath, and BD and Clarity. It's the sure test of the liquid-based cytology. So co-test is when we do HPV and cytology together, and then HPV only testing. It's it's can be co-testing or primary HPV screening. Interestingly enough, when we do a diagnostic testing with any of the above, it will be the same as screening test. So the technology is completely the same, and the CPT code that clinicians will be utilized will be the same. So it's only the matter whether or not you're doing as the screening or diagnostic, but the CPT code will stay the same. So we've talked a lot about screening guidelines, so I'm not gonna, spend a lot of time here. This is USPSTF screening guidelines. We're starting cytology at age 21. We're doing it until age 25, but at age 35 to 65, we can also add HPV only every 5 years or co-test also every 5 years. So why those methodologies are so important? And if I told you, I believe I told you yesterday that co-testing and primary HPV actually have much more sensitivity. So if you're doing the HPV alone, you're able to prevent, you're able to get to decrease of the deaths per 1,000 women to 0.29 deaths a year. Um, and that's very important number. So if somebody does not have any kind of screening, the deaths would be 8 women per 1,000 women, eight women per 1,000, without any kind of screening. So as you can see, HPV only prevents, the most number of the deaths per 1,000 women. If you're doing a testing, it's almost comparable results. It's zero point 0.3 deaths per 1,000 women. And cytology have, kind of a lower, ability to prevent the deaths. So it's 0.76 deaths per women. And that's why right now, the real push is really try to do HPV or testing after age 30. This is the guidelines from the American Cancer Society. We've talked about it yesterday. So they don't screen at age 21. They start at age 25, and they're utilizing HPV testing right away every 5 years until age 65. And this is comparison of the guidelines, but I'm not going to spend more time because we did the extensive discussion of that yesterday. So now let's look at the screening algorithm. So primary high risk HPV, as I told you, we screen for 14 types of that. And if we don't find anything, we go to routine screening every 5 years. But if HPV is positive, we immediately genotype HPV. We try to find out which genotype, which strain is present in a woman. And if it's 16 or 18, providers are recommended to go to cytology as the reflex. I told you about that. So we immediately test the same cells and to colposcopy right away. So with 16 and 18, we're going to colposcopy right away. If we're doing the genotyping and it's non-16 or 18, those two types that causes more than 70% of the cancers, we also do the cytology. Excuse me. And then, if the cytology is negative, we do the retest in a year with another HPV and cytology. Any questions regarding this algorithm? If no, let's look up. And sorry, we I didn't mention additional errors. So if it's negative, we go into the retest. But anything that is above negative, for example, ascus, this is the cells of undetermined significance, or higher, which may show precancerous condition, we immediately go to colposcopy. So continue to talk about screening and genotyping. So as we said, if the HPV screening is positive, we're doing the genotyping. If it's 16, 18, we're going to cytology and then colposcopy. Sorry. And with the colposcopy, there are two options that we can do. The first one is we're doing the biopsy, and we look and decide, what to do based on the cytology results, whether we find cancer or precancerous lesion. Another option, depending on the woman risk factors, her age, whether or not she already had children, we may do an expedited treatment, and it's called C and 3 lip, when we excise part of the cervix as the part of the colposcopy. Again, those decisions would be made, together with women, and it will depend, on her risk factors and whether or not, she completed her childbearing. Right? So let's talk about screening interval and most common questions. So, do people who have never had skin-to-skin genital contact can be screened? So the guidelines are silent on that. It's really individual, decision. And that's the reason why, sometimes we even screen women who claim to have no sexual contact. Are intervals any different for people who have multiple sexual partners? And we addressed that, in the previous presentation. No, the number of the sexual partners does not influence how we screen women. Using hormonal contraception and menopausal hormone replacement therapy, does that influence how we screen? Absolutely no. Those people who only have female partners, do we screen them? Yes, absolutely. So basically, the intervals will not be affected whether, people, have different, sexual, preference, such as lesbians. Remember, any skin to skin contact can lead to the infection, and people do use different kinds of toys during sexual intercourses. So all of those things, skin to skin and sexual toys, can transfer the virus. So if the woman is pregnant, do we change anything? Absolutely no. We screen pregnant women with the same intervals. Patients who have been vaccinated, we screen them too, and we will talk why we screen them. But absolutely, even people who received HPV vaccination should continue with the same screening guidelines. So, I've talked before about ACCP risk-based management consensus guidelines. So this is for women who have abnormal pap test results and abnormal HPV. And those guidelines, they are very individualized. So you put into the application all the previous history, her age, whether or not the woman is pregnant, previous results, and it will give you very narrowed down scenarios that ACCP is recommended to follow. Again, I encourage everyone to purchase that or at least utilize the web-based application. So let's speak a little bit about HPV vaccination. And actually, it's called now immunization. And the reason for that is that a lot of people, especially parents, they are concerned about word vaccination. So we try to use the word immunization. And this is kind of a, oftentimes difficult topic because it's still a childhood immunization. And there is a lot of myth about immunization, and unfortunately our not screening, excuse me, immunization rates are not as high as we would like to be, um, because people are concerned about this vaccine. They do not allow their children to have this vaccination, and oftentimes this myth comes from the fact that people link it mentally that if you immunize teenagers, they will be more prone to sexual activities. And of course, that's not true. We're actually trying to vaccinate, teenagers and young children before they become sexually active. But unfortunately, for many reasons, people think that the vaccination actually promotes sexual activity, which is not true. So, why it is so important to prevent HPV? As we mentioned before, we actually prevent not just the cervical cancer, it's just the tip of the iceberg. I really like this slide because it shows that we're preventing not that many, cervical cancer, but what we also prevent is cervical precancer. We also prevent oropharyngeal cancer, anal cancer, vulvar cancer, vaginal cancer, and penile cancer. So, and we recommend this vaccine for, again, young teens, age 11 and 12. And at this time, only 2 doses of HPV vaccinations are needed. So what we're trying to prevent every year in the United States, approximately 36 and a half, people, including men and women, both of them, are estimated to be diagnosed with the cancer that causes HPV infection. And although, again, cervical cancer is most well known, but we have to remember, other other cancers that are caused by HPV. And HPV can prevent more than 90% of the cancers caused by HPV, in general, in any part of the body. And it's estimated that that as I mentioned before, that those cancers are developed at least in almost 34,000, people in the United States every year. So this graph shows how many cancers can be prevented with the HPV vaccine, and this vaccine called 9V that stands for 9-valent vaccine. And as you can see, we prevent lots of cervical cancer, some vaginal, some vulvar, really quite a few of anal cancer, rectal cancer, oropharyngeal cancer, and especially, in male oropharyngeal cancer is really well prevented by, those vaccinations. Any questions regarding this slide or any previous slides? Okay, so let's talk about different vaccines. So in 2006, there was a vaccine developed by Merck called Gardasil, and it had four different types of the HPV strains 6 and 11, which are benign, and 16 and 18. And then in 2009, Cervarix was developed by GSK, but it only had the high-risk cancers. None of these vaccines available right now. The only one that we are utilizing is Gardasil 9 from the Merck, and it includes the benign HPV 6 and 11, and then also type 16 and 18. Again, 70% of the cancers, but also other high risk 31, 33, 45, 52, and 58. And it's usually 2 doses if it's given to children and teenager between age of 9 to 14. And if the vaccinations for whatever reason is delayed and we're giving it after age of 14, so from age 15 to 68, then we have to give the 3 doses of this vaccine. It's a different schedule depending on the age. And this vaccine became available in 2015. So routine immunization starts, as I mentioned, at age 11 to 12. So before usually, kids become sexually active, but it can be given starting as early as age 9. Catch-up immunization starts at age 13 to 26 for both male and females. And again, depending on the age, it can be 2 dose or it can be 3 dose. Um, in the past, we administered 3 dose vaccine. One was, kind of at the 0 time period. The second dose would be in 1 to 2 months, and the third dose would be in 6 months. Now, as we're doing the 2 dose schedule through ages 9, from ages 9 through 14, one will be at 0 time, and another one should be done within the year as early as 6 months. Also can be given with the other vaccinations that are due at that time for the teenagers. Um, this vaccine should be avoided if somebody has hypersensitivity to yeast or any of the vaccine component. Why be vaccinating the boys? I think the previous slides kind of, told us the story. So we trying to prevent all the other cancers, anal, penile, oropharyngeal. We also trying to prevent genital warts. And oftentimes, actually, when kids see the genital warts, they're really eager to get the vaccination because wart cancer means really nothing for them. But when they realize that it prevents all those, ugly lesions on their genitalia, they are much more prone to get these vaccinations. Also, it prevents the transmission of the HB virus to sexual partners. So what we're really trying to do is the herd immunity. So the majority of the people who are vaccinated are no longer being able to transmit this virus and able to fight this virus and have the immunity against those viruses. So that's why it is so important, for the herd immunity that everyone is immune, because as long as we have the pool of the people who are not immune, they continue to transmit those viruses between each other. So a little bit of the research. 9-valent HPV vaccine was studied in 3,200 women aged 27 to 45, followed by 3.5 years of the period. And what was observed that, this vaccine was able to decrease persistent infection, genital warts, precancerous cervical and vaginal lesions in 88%. Also, in men aged 75 to 45, the approval was based upon the efficacy in women in this age group, also earlier trials in boys and younger women, and also immunodeficiency data from 150 men in older age group. Why does it work in the older individuals? So we're talking about the group of the patients who are kind of beyond the age where Gardasil 9 is being covered by majority of the insurances. But these are the people who already most likely have been very sexually active. And we're talking about the age where FDA approved the vaccine but the recommendation that it should be individual decision whether or not these people, needs to be vaccinated, and also insurances do not pay for that. So we're talking individual of age 27 to 45. So if previously the person was not exposed, to the types that are in this vaccine, can protect them from the unmet, viruses. So, as I mentioned, CDC ACP guidance is permissive for this age, and it's subject to no cost sharing feature of ACA for ACF recommendation vaccine. Um, so, in regards to the shared clinical decision making recommendation, one individual may benefit from the vaccination, but it is very unlikely that it will have population level benefit. So most of the people in this age group will have either no or minimal benefit, because majority of the people in this age group have already met one of the viruses in this vaccine. Again, so it's individual decision, but we don't do it on the population based um, base, only because we are not able to protect people at this age because they already have been engaged in the sexual activities, and the benefit to pay for that from the public perspective would be very minimal. But who can benefit from that? Those people who have or plan to have new sexual partners, who have not been already immune to HPV through either natural infection or through the vaccinations, previously unvaccinated person who have never had sex, excuse me, sorry, wait. And people who are at high risk for acquiring new HPV infection in the future. Again, it has something to do with the sexual activity of the person. So there is a few slides about that family pact covers this benefit, but for the sake of the time, I'm going to skip on that because we don't cover the vaccination as the part of our program. There is a really great data that comes from Australia, because their school-based vaccination program has been super successful. And these are the results of the Australian research. If high coverage vaccination and screening is maintained um, at an elimination threshold of 4 new cases per 100,000 of women annually, cervical cancer could be eliminated completely as the public health problem in Australia in the 20 years. Unfortunately, our rates are not as high in terms of the vaccinations, but imagine that, such a large state as Australia, we'll be able to eliminate, this problem in the next 20 years. But what is important, it only can be eliminated if the screening and vaccination initiatives would need to be maintained, thereafter, to maintain low cervical cancer incidence and mortality. Like with any other vaccination, program, you cannot just stop the vaccinations or screening. You have to continue to be successful in elimination of the disease. So with that, I'm going to stop, and I'm going to see if you have any questions.
I have a question, Dr. Popova. For the HPV-associated cancers, is genital warts one of the symptoms that would warrant, having a consult with a doctor, or are there other symptoms that patients should be aware of?
Oh, excellent question. So, the presence of the warts doesn't mean that this person, carry also high risk viruses. There is no association, and there is no statistics that those who are affected by, HPV necessarily also infected with high risk. But usually it prompts, people to seek medical attention. And of course, every single time when we see, any kind of, papilloma viruses, whether it's the lower genital tract or a pharyngeal tract or anal tract, we would screen for high risk lesion. So it is a red flag, but it doesn't necessarily mean that, it's a diagnosis of the high risk cancer at the same time. Did I answer your question?
I did. I
Okay,
can
yes, it's
imagine
it's
that.
it's it's a really surprisingly, or maybe not surprisingly, those lesions are, so uncomfortable and ugly that people immediately seek attention. And of course, once they seek the attention, all the providers are very astute to, immediately screen them for high risk. And those symptoms usually, brings people, into the medical offices. And when we don't have it, people don't really realize that something can be wrong, because cervical cancer is really asymptomatic until it's already so invasive that it's completely protruding from the cervix, that may cause bleeding, some vaginal discharge. It usually starts to show the symptoms very late, when it's invasive and developed oftentimes to stage 4.
Okay, thank you.
Any other questions? I hope that this kind of, a little bit, deeper diving beyond, beyond just the guidelines, can help you with the understanding of HPV nature, and that although we're doing cervical cancer screening, HPV is really a much bigger beast, and causes much more cancers. And hopefully you will remember the graph of how many cancers we can prevent in men, especially oropharyngeal cancers, with the vaccination. So it's equally important for men and women. That's why we really don't distinguish when we're doing the immunization. Does anybody need a break, or we can go to breast cancer screening? Okay.
I'm okay to continue.
Okay, wonderful. So what I wanted to show you is the breast cancer screening in USPSTF. So the reason I'm showing you this slide, that the breast cancer screening recommendation also has this yellow banner, which means it's in progress. And we were expecting the new recommendation more than a year ago as well, but it seems like there is not enough, evidence, what to do with breast cancer tomosynthesis and MRI. And USPSTF, ask for additional time and additional feedback from the researchers and from the public. And this is the Dr. Maggion, who is talking about, and kind of, trying to attract everybody's attention to provide more evidence in regards to the utilization of breast tomosynthesis and breast MRI. Let's talk to the recommendation, the way how it looks right now. So those recommendations are from year 2016. So many, many years. And as you can see, the recommendation grade is B, C, and I. And let's talk about, what USPSTF, covers right now. So USPSTF recommend biannual, meaning, every 2 years screening with the mammogram for women age 50 to 74. They kind of reformulated what to do with women age 40 to 49, and they called it recommendation C. And if you remember, yesterday we discussed that when it's a recommendation C, that the decision should be individually based. It should be a discussion, with the patient, and assessment of her own, risk and benefits. In year 2009, these recommendations were kind of much more strict, when um, USPSTF also talked that, 40 to 49ers, can have breast cancer screening as the individualized decision, but it was truly the first time when it was kind of emphasized. And a lot of people, a lot of different subspecialties in the medical community, especially oncologists, radiologists, and surgeons, were against that decision. They truly believe that the screening should start at the age of 40. They see a lot of cancer at the age of 40, and they were fighting that decision to a point that human you know, I'm trying to remember HHS agency, came with the statement that although USPSTF recommends to start screening at age 50, HSSS was against this recommendation and really, wanted to make sure that providers continue to screen women at age 40. So there was a huge fight, and it kind of lingered, all these years. That's why, the recommendation is now more softened, and I'll show you the comparison from the other work groups. But a lot of people were against the recommendation to start screening at age 50. They felt that recommendation should be very clear to start screening at age 40. And it happened, this recommendation came into light in 2009, exactly at the same time when EWC closed their doors to new women and women 40 to 49 because we ran out of the budget. So our program did not close the door because of this recommendation, but it coincided. And I probably told you the story already, but you may hear about it. So I want to give you a little bit of a perspective that we were under so much scrutiny that we had 3 audits from the state, how we serve our women and how we use our money. But the reason for that, super high expenditure was absolute, incredible increase in the number of the women that we served. That was the time when we served more women than we ever served before, and that was around, year 2009. And it was the time of the budget crisis in California. And the audit basically showed that we did excellent job. We did due diligence, and we were the only program in the Department of Public Health at that time that got augmentation with general fund. We didn't have general fund before, and that was the year in 2010 that we received general fund. And in spite of the fiscal crisis in California, we were the only program, as I said, that were getting additional money for screening. So, talking about, the recommendation for women age 40 to 49, so the decision to start screening mammography in that age group should be individualized. Women who place a higher value on potential benefit than the potential harms may choose to begin biannual screening between age 40 to 49. So when it comes to our program, we don't release any kind of recommendation. We're not really in that role or the position to kind of, develop our own recommendation. And we're not policing the providers. They are at the liberty, as well as the patients. They are at the liberty to choose, the schedule that, they seem, to be appropriate. But what we do, we have a payment policy, and our payment policy allows our women to start screening at age 40. And we not dictate how often either. So it can be once a year, it can be twice a year. It cannot be more often than once a year, but they can choose to do annually versus yearly. Any questions here regarding screening recommendations?
No.
Okay. So let's talk about digital breast tomosynthesis. So this is the new modality, and I believe I talked about it, a little bit. So it's a little bit more advanced than, just digital mammography. So tomosynthesis is able to do, additional, cuts and construct what we call 3D mammography. So digital mammography is pretty much 2D mammography, and digital breast tomosynthesis is 3D mammography. So you're able to kind of construct the picture of the breast, that looks like, a volume organ. And, you can see it, from different angles. Um, it's interesting enough that digital tomosynthesis almost replaced 2D almost everywhere. A majority of California radiological facilities, have, additional um, machines, or or function of the mammogram machines, to provide digital breast tomosynthesis. So it's not even possible right now to find the radiology facility that only do 2D mammography. And there's quite a few reasons for that. So if you understand, how 3D is different from 2D, you can definitely see that you have, much more, ability to manipulate those, images, to magnify them, to look, from the different angle, to compare them, to save them. So there's a lot of things that comes with the technology that makes life of the radiologist, much easier, not just from the perspective of functionality, but also from the perspective of being able to read certain things more. And there is one unique quality to tomosynthesis um, that is not only sensitive, but it's also specific. So sensitivity is when we can identify, lesions most of the time when they're there. But specificity is the quality where we can eliminate lesions that appear to be there but are false positive reading. So digital breast tomosynthesis does not have many false positive readings, which is usually a feature of a diagnostic test. So it combines features um, of screening test and diagnostic test. And this is very unique because you want to find, potential cancers, but there is always, false positives readings. With the diagnostic test usually, very good in terms of eliminating false positive and really see something when something is really there. And tomosynthesis have it all. So we have a very low um, a recall rate for the tomosynthesis. So if something is identified, most likely something is really there and you can biopsy it. That's why digital breast tomosynthesis, became such a popular methodology. But when it comes to the research, researchers not only need to prove that this modality able to identify cancers, but that on the long run it also able to decrease mortality and morbidity rate. So we're not looking just at identification of the cancerous lesion, but we're also looking at the net benefit effect at the very end, whether or not it really influences our numbers for mortality and morbidity. That's why, there is still no clear recommendation from none of the expert work groups regarding tomosynthesis. So it looks like, the practice is already there. People use it. It's the, kind of, standard of care. It's a quality care, but we don't have enough research that backing it up. And that's why recommendations are kind of delayed in spite of that everyone is using tomosynthesis. I will tell you, for us, it was almost like a personal fight because we had really big challenge to make it a benefit. CDC made this a benefit quite a few years ago, and it took us to fight with the Department of Finance to add this to our benefits, and it took us 6 years, which, in my opinion, is almost a crime to delay it for so long. Um, and the reason is that Department of Finance saw that our caseload is going down, and they were wondering why you're adding a new big benefit. And unfortunately, um, we, me as a doctor and my nurses are not able to testify. It's other, management and administrators talk to each other and they don't understand that quality and quantity is two different things. Even if we screen 100 women, we should have the same benefits as medical and other insurances, and we should be able to have, the most recent methodology and procedures to be able to cover for our women. So getting tomosynthesis on board was a huge fight, but we were successful. And I can tell you that now our women in EWC are able to get tomosynthesis at any of the medical facilities. But again, right now um, the the guidelines, USPSTF and others are silent on that. Um, does anyone know what dense breast is? What do you know about it? Can you tell me? Anyone? Okay. If not, let's talk a little bit about dense breast. So, dense breast is when you have more connective tissue in the breast rather than fatty. And I'm going to show you this picture. Are you able to see these images?
Yes.
Okay, great. All right. So, women's breast, is different. And there is a lot of factors that goes why we may have more fatty tissues versus more dense tissue. There's sometimes also some, ethnic and race factors that may influence it. For example, Asian women more often have dense breasts. But in general, if you look at the entire population, and let's say we have 100% of women, we will have 10% of fatty breasts or 10% of women that have completely fatty breasts and then have 10% of extremely dense breast. And as you can see, dense breast looks white, the same way cancer looks. So 10% of the women on average have completely fatty breast. And then 40% of the women have scattered fatty breast. So they have some dense, tissue, but mostly it is fat. And then we have heterogeneously dense, where fat and connective tissue, it's kind of almost like 50-50. And then we have extremely dense breast when everything completely looks white. So it's 10%, 40%, 40%, and 10. So it's interesting that this is one of the risk factors. It's not the most important, but it's one of the significant risk factors. And it has significance that dense breast on its own is the risk factor. So having more dense breast, you know, uh, increases women's risk to develop breast cancer. But also the fact that it looks white, so it's hiding the cancer, is adding to the risk. So having dense breast, put you, at risk from, two different, standpoint of view. In 2006, there was a lawsuit in Connecticut from a woman whose cancer was not identified in time in spite of her having a regular mammogram. And when this case was reviewed, it looks like, she had the cancer for quite some time, but it was hidden because of the dense breast. Since then, there was legislation in Connecticut that asked providers to discuss dense breast with women and offer additional screening. And that was like a wildfire. After 2006, almost, I believe right now it's almost all states in the United States have the same legislation, and some of the legislation just, inquire providers to inform women that she has a dense breast, which is a risk factor, and encourage her to talk to the doctor about her dense breast. But in some other states, it also pushes providers to do additional screening. Um, so this kind of issue is more than 10 years old, 15 years, actually, well, almost, well, 17 years old. And in spite of that, we still don't have a really strong recommendation which modality is the best to assess dense breast. Again, majority of the research points out that tomosynthesis is probably the best modality for the dense breast, but there is no official recommendation. And when this, notification came into effect in California, I believe it was in 2012 or 13. Sorry, I don't remember right now the year, but it was, pretty early on. I think we had it already for 10 years. And in other states, the problem was that uh, there is nothing that is recommended by any of the guidelines what to do, and providers were at loss, especially primary care providers. What should we do? Should it be MRI? Should it be ultrasound? Should it be tomosynthesis? And really, even now, we don't have the recommendation or specific recommendation that talks about dense breast. And until then, we're probably still kind of in this ubiquitous situation where we almost have to do something, but no one knows exactly what to do. And for our women in EWC, what we have available is that women, can get tomosynthesis from the get-go as the screening modality. And oftentimes, whether women is EWC or non-EWC, if her previous images show dense breast. Most of the time, radiological facilities, try to schedule women for tomosynthesis because, as I mentioned, facilities have both capability of 2D and 3D, but they try to make sure that women with dense breast always get 3D at the baseline. So that's, one of the possibilities. The second is, they can do additional ultrasound or even MRI when something looks ambiguous or questionable on a mammogram. Uh, but again, there is no specific recommendation. So I'm going back to USPSTF, and this is what they say. And that's why there is a delay in the new recommendation that women with dense breasts, that there is no current evidence or the evidence is insufficient to assess the balance of benefits and harms of adjunctive screening for breast cancer using breast ultrasound, MRI, DBT, or other methods. So don't be surprised when you see this recommendation, but know that what is happening in the community, that providers are doing, one of them, and sometimes maybe a few of them for the same women, and that the majority of the women with previous reading of the dense breast is getting the DBT or 3D or tomosynthesis, in other words. Any questions regarding dense breast? No. Okay. So the last recommendation is when we should, stop doing the screening. Um, So USPSTF is stating that women age 75 or older, that there is no insufficient, evidence to assess the balance of benefits and harms of screening for women age 75 and older. I don't want to comment specifically on the age, but the reason that screening should be stopped at some point is due to the fact that, if you identify the cancer, uh, and you start cancer treatment, you really affect quality of life and sometimes even, may affect it in a such a way that it may not prolong the life, but it will, increase the suffering. And if women have multiple comorbidities, if she most likely will die from another disease, and we subject her to radiation, chemotherapy, operation, we may actually shorten her life. So there's always should be a point where you probably shouldn't be, treating someone who is already sick enough. But the question is when. And I, it looks like, they may be more awake next time the recommendation comes around because I think that 75 years of age is very, arbitrary. And right now, with the fact that people usually have longer life and not as many comorbidities due to successes in treatment of the chronic conditions, this age period can be pushed. That's why I want to show you a different table. Um, where we're comparing different oops, excuse me, this is not very convenient website, so I may need to go back to this slide because it changes on its own. So as you can see right here, age to stop mammography. So the first is the American American College of the Radiology, American Cancer Society, American College of Obstetrics and Gynecology, American Medical Association, National Cancer Institute, and USPSTF. So as you can see, excuse me, it's not NCC is not American Cancer Institute, it's National Cancer Network. So as you can see, they have a very different formula of what they say. So American College of Radiology does not even put any age limit. ACS says when the life expectancy is 10 years of age. Of course, it's very difficult to assess, but it doesn't really look at specific age. It looks at how well the woman feels, again, what kind of comorbidities she has. ACOG is also saying 75, the same as USPSTF, but AMA and NCCN does not really states the age. So I think it's really individualized decision. But what is important to remember that, at some point, health educators in our program would be going to like nursing home and, try to get people to screen there. And that was a really wrong move. We no longer doing that. It's been stopped quite a while ago. But it is important to remember that we really have to, concentrate our efforts on women who will benefit and who will not suffer from screening. So that's one of the, major things, to consider. And please also remember that the age is the second risk factor for developing cancer, which means that the older the woman, the more likelihood she will develop cancer. So with age, cancer will progress. That's why it is very important to find this balance between, when you stop screening or when you still continue to do the screening. And I wanted to show you this table that there is still kind of, discrepancy between different guidelines and what they recommend. So there is still some disagreement. That's why our policy, again, is about payment and it's permissive because you can see that majority of the guidelines starting mammography at age 40. It's only USPSTF, starts at age 50, and ACOG states that it should be initiated no later than age 50, but starts offering at age 40. American Cancer Society, I believe in 2016, came up with kind of, halfway recommendation, which was surprising to all of us. So they kind of choose the number in between 45. And remember, age is very arbitrary things. The nature does not really measure everything in 10 years, interval. It is something that people do. So ACS, came up with the option that the mammography should start at age 45, with the option to start at age 40. And also the intervals are different, as you can see. Some groups recommend annual, some recommends, every 1 to 2 years, like American, College of Obstetrics and Gynecology. And then ACS, interestingly enough, recommends annual screening age 45 to 54. But then after age 54, starting at age 55, every 1 to 2 years. And again, as you can see, majority of the groups doesn't really state recommendation regarding tomosynthesis, but American College of Radiology states that it improves cancer detection rates and reduces recall rates, what we, discuss, with each other. But so far, it really does not recommend yet, 3D mammography, and there is no really word for, for the dense breast. So with that, I think look at our, guidelines. I think we looked at everything. And let me bring up our team screen. And I would like to ask you, do you have any questions? Are you comfortable with discussing the topic now of when to start, when to stop breast cancer screening? What is tomosynthesis? What is dense breast?
Yes.
Yes.
Okay, and I want to mention, if you remember, all this time we've been talking about women at average risk, and then with the high risk, as I told you before, women would be screened annually with mammogram and MRI, which can be done at the same time or which can be done, every 6 months, alternating, one modality after another. And it can be started before age 40. Usually it starts at 10 years before the first degree relative was diagnosed with, breast cancer. And some women may even, start mammography and MRI screening in her 20s if somebody was diagnosed in their 30s, in terms of the relatives. So again, any questions, any concerns, anything that you want to, provide us the feedback?
I know you were recording the presentation. Will those recordings be available to us, or was that just for like
I
state
hope
reference?
it will be. Erin,